Hello, everyone, and welcome to CLAN's Parallel event brought to you by CLAN, Mates for Kids, and Lehigh University. My name is Mabel Cudmore, Community Development Officer for CLAN in Indonesia and Australian New Colombo Plan Scholar. I'll be co-hosting this morning with Kate Armstrong, President and co-founder of CLAN, and Elizabeth Page, also a Community Development Officer for CLAN in Indonesia and New Colombo Plan Scholar. Before we begin, please ensure you are on mute. If you have any questions or comments throughout the event, feel free to post these in the chat. Lastly, this event will be recorded and posted with a report soon after on CLAN's and Mates for Kids website. We would like to acknowledge the lands that everyone is dialing in from. We invite you to post the traditional lands you are on in the chat now. We acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters, and community. In particular, we'd like to acknowledge the Wallumedegal people of the Eora Nation, on whose country CLAN is headquartered in Sydney. We pay our respects to First Nations people internationally and to their culture and elders, past, present, and future. Today, I speak to you on behalf of CLAN's partnership with the New Colombo Plan. The New Colombo Plan is the signature initiative of the Australian government that aims to lift knowledge of the Indo-Pacific region in Australia by supporting Australian undergrads in studying, learning languages, and undertaking internships in the region. Since 2017, CLAN has hosted New Colombo Plan scholars in Indonesia, the Philippines, and Fiji. Throughout this process, as a scholar myself, I have built invaluable relationships and knowledge with the community here in Indonesia. I'd like to thank Professor Aman Palungan and Yayasan Kesehatan Anak Global Team for hosting me. This year, United Nations Commission on the Status of Women theme is accelerating the achievement of gender equality and the empowerment of women and girls by addressing poverty and strengthening institutions and financing with a gender perspective. At this CLAN and Mates for Kids parallel event at the non-government organisation Commission on the Status of Women Forum, our session is titled Accelerating Gender Equality and Empowerment for the International CAH Community. Children and adults with chronic health conditions such as CAH in low and middle income countries frequently face challenges accessing affordable and quality healthcare. Complex social, political, and economic factors result in gendered inequalities, most often impacting women and girls. Today, we will be hearing from those with lived experience about how gender inequality and poverty intersect to impact care, health outcomes, and quality of life for people living with CAH, with special attention on the experiences of those born biologically female. We will celebrate the strength and resilience of the CAH communities who are working to drive sustainable change. We will also be highlighting the importance of newborn screening as a tool to promote early and equitable access to diagnostic and therapeutic options for kids living with CAH and other non-communicable diseases. We will also highlight the important role the newborn screening must play in supporting efforts to achieve the 2030 Agenda for Sustainable Development. Congenital adrenal hyperplasia, known as CAH, is an inheriting condition affecting the production of two hormones by the adrenal glands, cortisol and aldosterone. Fortunately, CAH can be treated with two essential medicines, hydrocortisone and fludrocortisone. When these medicines are used, children with CAH should be expected to live long, healthy, and happy lives. Unfortunately, children and families living with CAH in resource-poor settings often are not able to affordably access the care they need. We feel the experience of women and girls living with CAH deserves special attention, especially given the extreme differences in quality of life experienced by those in high as compared to low-income countries. People born genetically female with CAH in lower income countries often experience extreme isolation and social stigma, particularly if they develop sex characteristics that don't conform with what is culturally expected of their gender. I would now like to introduce Dr. Andrew Tuminanesco, to introduce CLAN and speak on behalf of CLAN Africa. Dr. Andrew is a Ugandan medical doctor, public health specialist, and research manager at Seed Global Health. He is passionate about the health workforce, non-communicable diseases, and child health. He has led CLAN's community-based initiatives in Uganda, supporting the nodding syndrome and epilepsy communities, and is currently the Community Development Officer for CLAN Child Health Africa. Thank you, Andrew.
Thank you so much for the introduction, and a very good evening and good morning to everyone, depending on where you're logging in from. I'm pleased to speak to you today about CLAN and an introduction to CLAN. CLAN is caring and living as neighbors. If you could just move to the next slide. And it's Australian-based organization with an aim of maximizing the quality of life of children and their families who are living with chronic conditions. Whereas it has worked in several countries, but majority really and major focus is on resource-poor settings around the world. Later on today, we'll be hearing about so many countries, and they will be sharing stories about the works they've done with CLAN. And next, please. So I wanted to speak to you about this approach and how the approach has really been able to change a lot of lives of children living with chronic conditions all over the world, but importantly, CAH. And also just note that this model is applicable to any of the chronic conditions. It's been tested through, we've worked with congenital adrenal hyperplasia. We have applied it in epilepsy communities. We've applied it in nodding syndrome communities. We've applied it in type 1 diabetes communities. And really, it's important for us to understand this strategic framework. Now, this is a rights-centered approach, community-based approach that puts the children and families living with chronic conditions at the center with 5 key pillars. And I'll quickly go through each of the pillars. The pillar 1 is ensuring affordable access to medication and equipment for all children really living with chronic conditions. And later on, we'll hear from some of our colleagues and which works they've done through each of all these pillars. Pillar 2 focuses more on education, research, and advocacy to ensure that the families and the communities living with children having chronic conditions are able to have all the information they need, research putting into evidence-based practice, and advocacy to ensure that they really get the best out of whatever approach they are looking for. The pillar 3 that looks at optimal medical management. In this case, it focuses on ensuring that every child living with chronic condition is able to get medical attention they need at any of the level care facilities that they can access. Pillar 4 focuses on ensuring encouraging family support groups. And in this case, we believe that if families and communities come together when they are sharing the same issue or challenges, then it's always half solved. So CLAN works so much to ensure that communities establish these support groups that are community-led and community-centered. And in a long run, they end up being independently run without CLAN's involvement. But these support groups have proven to be so much successful at achieving the set objectives. And these family support groups have been established across all the chronic conditions CLAN has worked with. And we'll hear a story later on from the CH community in Zimbabwe and a number of other colleagues that will speak to us later. The last pillar, which is pillar 5, speaks about reducing poverty and promoting financial independence. We believe that and we understand that sometimes chronic conditions or any disease may have a very strong negative financial impact on the families. So this creates an opportunity to ensure that there are approaches and initiatives at tackling this. And of course, this kind of works closely with the rest of the pillars. And at the end of it all, we ensure that we have the highest quality of life for children living with chronic conditions. Next, please. So I'll be speaking about Clan Child Health Africa. After years of working with Clan and support from Clan to ensure that we do a lot of activities in Uganda, of course, Uganda was successful in terms of running the nodding syndrome community, one of the chronic conditions that affects a number of children here. So we felt that Africa is one of the regions that extremely struggling in terms of available resources, but also these are some of the conditions that need special attention. So with support from Clan, we established Clan Child Health Africa, based here in Uganda, but supporting all our work all over a number of countries in the region. And it's hinged on the 5-pillar model or strategic framework that I earlier mentioned. Currently, we've run activities in Uganda, Burundi, and Zimbabwe, and we'll definitely have a later story to tell from Zimbabwe. So in Uganda, we've run nodding syndrome and epilepsy communities, and we've successfully launched the community support groups. The community is also benefited in receiving some mobile phones to advance telemedicine. This was an innovation during the COVID-19 period, since communication and movement was limited. We've initiated activities in Burundi around type 1 diabetes communities, and we successfully conducted a community awareness and education event. Zimbabwe will definitely have a more deep dive later on from one of our champion, Trudy. But we have a CH community in Zimbabwe. We established a successful community support group, and Clan has greatly supported shipping a number of medications for CAH to Zimbabwe, with the first shipment that sorted accessibility to medicines issues for close to a whole year. And currently ongoing plans of ensuring that more medications are pushed into Zimbabwe as the country and the community evolves to ensure that it self-sustains itself. Next. Okay, so that's a brief introduction to Clan. I just wanted to take 1 minute of silence to honor one of our champions' mom, and later on we'll definitely hear from Trudy. On a sad note, we lost Trudy's mom a few days ago, but we just want to thank her for raising a very wonderful lady, a very caring lady, and we hope that her soul will rest in peace, but we keep celebrating the life she brought up, and we'll keep remembering her. Let's take a few seconds, and then feel free to introduce the next speaker.
Thank you so much, Dr. Andrew, for sharing. And we would just like to really thank Trudy for coming here today, especially since the death of her mother. And we'd really like to honor her mother for giving us Dr. Trudy and all the amazing work she does. I would now like to introduce Dr. Kate Armstrong, co-founder and president of Clan, to speak on behalf of Mates for Kids.
Thank you very much, Mabel, and thank you very much, Andrew. Trudy is a remarkable woman, and as a mother myself, I feel sure her mother will be very proud of all that she's achieving. It's a real honour to all be together today. Next slide, please, Mabel, for the CSW event. And the theme we felt really speaks to what we're all trying to achieve as the Mates for Kids community. So my talk will really be introducing Mates for Kids and giving a bit of a brief introduction to that. I think we'll find when we hear all the stories from the champions today that work around strengthening social protection systems, improving access to quality healthcare and public services and sustainable infrastructure, those themes will come out very clearly today. And I believe that the work that the Mates for Kids network is doing to accelerate gender equality and empower the international CAH community is making a true difference in the world. I'd like to acknowledge that I'm dialing in from the lands of the Wallamadigal people of the Eora Nation and pay my respects to elders past, present and emerging. I'd really like to acknowledge all of the elders and leaders in the field that we work in, and I'd like to take a moment to acknowledge Leslie Holroyd, who is a woman, a remarkable woman living with CAH. She was born in the UK and then moved to the USA. She was born at a time when CAH had only just been diagnosed, really sort of like understood. She was one of the earlier people to live with CAH. And she had a very challenging journey, but she's such a resilient, strong woman and so open to sharing her story. I'd really like to acknowledge Leslie. She was going to join today, but she's not well. But we'll be putting some links in the chat to podcasts that CARES Foundation did with Leslie. And I'd really encourage you all to listen to those podcasts after this talk, and we'll be sharing them links in the report too. But it's women like Leslie that really help us and inspire us and help us aim for really great outcomes for all people living with CAH. So just a brief overview of what I'm going to quickly talk about now. Introduce Mates for Kids, what we're trying to achieve, 30% by 30, and just the approach we're taking led by champions. So Mates for Kids is an international coalition of individuals and organisations, and our big, hairy, audacious goal is reducing the preventable mortality associated with CAH by 30% by 2030. We know that this will contribute to member states achieving the SDGs, and I'd really encourage you to have a look at the briefing paper on the Mates for Kids website if you'd like to learn more. How are we going to do this? We're going to reduce preventable mortality in 3 ways. We're going to be improving access to essential medicines and equipment, strengthening CAH communities and scaling newborn screening. And I think that our champions today will be showing how we're going to be achieving that. With regards to access to medicines, I'd just quickly like to note that every child has a basic human right to life and health. And to live with CAH, you need access to essential medicines. Hydrocortisone and fludrocortisone are on the essential medicines list for children put out by WHO. And I'd just like to acknowledge there's images there of Dr. Paola in Colombia and Trudy and the team in Zimbabwe, the work that so many are doing around the world to improve access to medicines. Strengthening CAH communities is so important. We just recently had the CAH meeting in Colombia, and we'll hear all about that today. Recent meetings in Fiji. So many people around the world doing great things to build communities. And what is truly lovely is the different CAH communities reaching out to one another and sharing messages of encouragement and support. So this is an example from the message from Kahaki, the community in Indonesia that they sent to Colombia. It's that sort of connectivity that's building internationally that's going to make us all so much stronger. And finally, scaling newborn screening. Dr. Agostini, Indonesia, is going to tell us of the remarkable achievements they've been making. We're hoping to have a side event at the World Health Assembly this year to celebrate that even further, but it's just truly remarkable. So as I mentioned, we're all coming together from all the 6 WHO regions of the world. We're grateful to WHO for hosting us on their Knowledge Action portal, and Elizabeth will include in the chat a link to how you can join the CAP if you'd like to read more. But we come together, we tell stories, and we start building this toolkit that we have of resources and knowledge. And there are a number of reports that are on the CAP and also on the Mates for Kids website as well. So that's just a brief introduction to Mates for Kids, what we're all trying to do. We'll be including a link to our report in the chat as well from our most recent UN event at the Commission for Social Development, and we'll share this report as well in the future. But now it's time to hear from everyone else. Thanks, Mabel.
Thank you, Dr. Kate. I would now like to introduce Dr. Ili Varetti to speak on behalf of Fiji. Dr. Ili has 27 years of experience and has an interest in neonates intensive care research and epidemiology. She is currently the head of the pediatric department at CWMH in Fiji and is the sub-regional chairs for measles elimination and the polio eradication PICS and arrears. Thank you, Dr. Ili.
Thank you, Kate. Thank you for the introduction. Bulavinaka is the way we say hello from Fiji. Good morning to everyone. I'm very happy to present on living with CAH in Fiji. Next slide, please. So towards the fourth quarter of 2023, we had a newly launched hospital in the home initiative at our hospital, which saw hospital staff visiting patients and families in their homes to better understand their healthcare needs as well as increase access to essential healthcare. The hospital in the home began with a particular focus on the NCD community and families, and it was from these meetings that it became obvious that a support group and community connection would be extremely beneficial to our families. It was through this that common misconception and myths about causes for NCDs was addressed, and a need for increased education was also recognized. To address both of these concerns and to celebrate the NCD community in Fiji, an event was planned to coincide with the celebration of World Children's Day and International Day of People with Disability in November of 2023. And the event was highly successful in its turnout of 9 of the 10 CAH families in the capital region in attendance, and invitations extended and accepted by the Australian High Commission, our CEO of the hospital, other administrative staff in the ministry, in the department, our partners, donors and collaborative partners in Frank Hilton and Rehab Hospital in the country, and the passionate doctors and nurses of our hospital itself. And we were fortunate we had the presence of media. Our national newspaper, which covered the event. So next slide, please. Oh, sorry. Some key okay, I could you just go to the next slide? I think you've got the wrong slide up. Go back, I think. Sorry. Another one, go back a bit. Yeah, I think it's one, just leave it at that. Sorry, so these were some of the key highlights from the event. First was that of the attendance and address by the Australian High Commission and First Secretary, Ms. Flo Kilcutt, who demonstrated Australia and Fiji's strong partnership in helping children thrive in Fiji. Another important aspect of the event was the information talk provided by one of our pediatric doctors, who addressed commonly held myths amongst the community surrounding CAH and its cause. It also raised awareness for the guests that were there, who many were previously unaware of the condition. Our partners also, the Frank Hilton Organization and our Tamavua Rehab Hospital partners also provided insight into the tremendous works and support to the disabled community of Fiji for both children and adults. And another key highlight was the parent testimony, which will be discussed in the next few slides. So next slide, please. So this is first-hand experience from a parent testimony. The gentleman you see in the picture is one of our fathers, Mr. Dangida, who's also a school teacher, who courageously spoke to those in attendance about both the challenges and strengths that have come with his two children with CAH diagnosis. He expressed openly and honestly about the impact CAH had on himself as a teacher, as a father, his wife, and their family unit as a whole. He highlighted common stigma and judgments that follow a diagnosis of a chronic condition such as this. He also expressed the difficulties a diagnosis like this can have on a marriage and family dynamics, as well as misunderstanding of the cause of CAH, leading to thinking one parent was to blame. He also shared his wisdom on how to overcome these hardships and see CAH diagnosis more as a strength and not just a weakness or a challenge. Next slide. So the strengths he talked about, he beautifully demonstrated the way family and wider community members can be leaned on rather than pushed away by recognizing their intent and finding helpful advice. And in this way, a support network, which is so necessary to navigating chronic conditions without the isolating effect. Mr. Dangda particularly drew attention to the way in which his wife was able to also use her skills of caregiving and providing for their ill daughter with CAH for 9 years to gain employment. His wife was later able to gain employment as a ward assistant in a big hospital due to her extensive and valuable skills learned through this experience as a mother of child with medical needs. He also explained how his son had gained an increased sense of thoughtfulness and kindness towards others, and has even become determined to be a doctor to help his sister and others like her. Next slide, please. Yeah. So his speech was also an extremely powerful element during the day, as it allowed for lived experience to be shared with guests and others in the CAH community. For many of the CAH families, his stories would have felt familiar and inspired hope and courage amongst them. It also allowed for a voice from within the community to be heard and to lift the entire CAH community into recognition and empowerment, and to feel as though their struggles were heard, understood, and could be addressed. This lived experience helped many who were previously unaware or may not often see the other side of a diagnosis in a family to understand the impact of living with not only CAH, but also many other children and families living with NCDs. And the speech remarkably inspired hope amongst them, but also the wider community to ignite awareness and recognition, and uplifted the community as a whole. And so that was the day. The day for us in Fiji. It was very successful, and we were blessed to have heard more about CAH and living with CAH from a family itself, a family unit itself. So thank you. That's all from us in Fiji.
Thank you, Dr. Ili. I would now like to introduce Trudy Naya Kambangwe to speak on behalf of Zimbabwe. Trudy is a highly qualified social scientist and rare disease advocate with over 20 years of experience in the field. She holds a PhD in child-sensitive policy and a master's degree in child and family studies. Trudy has dedicated her life to working with marginalized community with a focus on improving recognition, access, treatment, and care for rare disease patients. Thank you, Trudy.
Thank you very much, Mabel, for the introduction. I'm happy to be on this platform to share with you to share on the work that the CAH community is doing to support themselves. We like our work to be led by the patients themselves because they know what is most suitable for themselves. So we are thankful for CLAN for being part of our growth, as they are the organization that has supported us from the very beginning. When we started in 2018, we had about 4 families that we had been able to identify. And then as we continued to raise awareness and as we continued to engage one of the hospitals here in Harare, we then created access, opportunity for more people with CAH to join our group. Next slide, please. So Zimbabwe is a country with about 16 million people. It is in the southern part of Africa, and with 80% of families using the public healthcare system and only 20% in the private sector. There is great need for support for these communities because we are a low-income country and medical aids do not cover families that are living with conditions such as CAH. Next slide, please. So we have also been following the pillars that Andrew mentioned earlier in terms of our programming and in terms of running our activities here in Zimbabwe. We have been fortunate to get support from CLAN and have received hydrocortisone and fludrocortisone for our community. For the past 2 years, we have been having a really smooth flow in terms of them accessing medication when they come in for their monthly clinics. We are still hoping to receive more medication to support this family, but I would just like to share that while we are waiting for the next batch of medication to come in, we have experienced amazing support within the community itself. So we have some families who have access to more medication, who can afford to buy for themselves, giving other families who don't have any medication. So this is a new development which has come through, and we find that really amazing that they are learning to support each other while we wait for the next batch of medication to come through. We continue to thank CLAN for this support as we lobby and advocate for fludrocortisone to be added onto the essential drug list so that it becomes more accessible here in the country and also more affordable. Next slide, please. So in terms of raising awareness and educating our community, we have had a number of activities throughout the past 3 years. The most recent one being the one we had last week, that's our Rare Disease Day, which unfortunately I did not attend, but the CAH community was there. I hear it was an amazing event. So we had our doctors present to share with the communities and answer their questions. We had policymakers from our city also attend this program. And it is really amazing the amount of information that our community has now, as they're able to ask more intelligent questions and also to, put our policymakers to account in terms of how they are going to be supported as we continue to grow this community and get more access to educational material through our collaboration with CLAN. The next slide, please. Next slide is on optical medical support. Okay, so because there isn't enough awareness among our healthcare professionals, we then went out and did a small card which the families can keep in their wallets and take with them to any medical practitioner in the event of a crisis or if their child should fall sick. So it gives details on the condition and how they are managed when they are going through a difficult time. So this is important because not everybody knows CAH, and we are aware that we are actually losing some of the CAH children because of this lack of awareness. This is something that we need to work towards as we go. And I am happy to hear about the newborn screening that Kate was sharing, because that is one very good way to actually catch our CAH children before they go into distress, and we can manage and make them better and grow as healthy children. Next slide, please. I mentioned earlier that the support that they give each other is very good. We continue to have more this year. We've 23-24, we've had 3 more families join our group, and they feel at home because they feel like they are one big family and experience the same issues. And even when we meet, some of them can share, they can cry, they can talk, and they feel it's a safe space. So we are really happy about the support group. It is really a lifeline for families living with CAH, and it reduces isolation and stigma and empowers them to be able to stand for their rights. We also need to note that our children continue to have challenges within the schools that they go, and they usually come up with ideas and solutions in these support groups as how to manage that challenge. I know one family has moved their family from one school to another, and they are reporting an improvement in the quality of support in that new school as a result of a referral from the support group. So we really hope to grow this group and hope that families continue to benefit from what they can share among themselves. Then next slide is talking about empowerment. I mentioned earlier we're a low-income country and families are struggling financially. As we all know, CAH is a lifelong condition which becomes a burden to families as there are no medical aid covers. So we empower families through income generating projects. Last year, we were running a chicken project. So they were able to, we bought chicks and feed and vaccines for them. They then looked after the chicken and sold them and brought back part of their profits so that we could give to the next group, because we didn't have a lot of income to start off with. And that cycle allowed each family to eventually have their own birds and to continue selling and generate a little bit of money that can support in terms of transport to clinic, or in terms of bloods and other medical requirements that they constantly have to pay for out of pocket. We have also engaged another organization that does empowerment to support this initiative, because we are not really well equipped as child and youth care. So we have decided to engage another organization that does empowerment program for women in Zimbabwe, and they are taking over the projects for us. We will continue to support our families, but in terms of capacity, that new organization will be taking over in 2024 so that they are strengthened and continue to generate more and more income. We are helpful for the health fund, which is being funded by these projects, and hope it continues into the coming years and grows to a point where we don't do out of pocket. And then I think the final slides, where we talk about achievements. So in the first year when we met Glenn, we lost 2 children. We haven't lost a single child since we have had this relationship, because we now have medication, and so our families are well taken care of. We hope we get our medication soon and continue to reduce the mortality rate. Our families are empowered, and there's so much increased knowledge, not only with the families, but as well as the healthcare professionals that support them. So what are our challenges? In the next slide, we continue to have regulatory issues in terms of bringing in medication. As you all know, medication coming from one country to another is always a challenge. And we are working with the help of our pharmacists to try and bring in the medication as soon as possible. We also continue to have challenges because even if you can afford to buy the medication, it's not easily available in our local pharmacies. And we are still worried about the cost. I think it's around $50 per month to get a dose for a family. That's still extremely high. We continue to lobby with our government so that they can subsidize that for us. Limited funding is still a challenge, and also understaffing in specialty care because we only have one doctor who's an endocrinologist. So as we conclude, we are really proud of the achievements that we have made together, and we hope that we continue to collaborate and advocate for the CAH community, as well as allow them to advocate for themselves by creating platforms that enable this. It is vital that we work together as change is bigger and stronger if we work together from different spaces, different parts of the world. We are able to achieve more. Thank you.
Thank you, Trudy. I would now like to introduce Jeff Gagandahan to speak on behalf of the Philippines. Jeff is the president and co-founder of Intersex Philippines, which pioneers advocacy for equality and protection of Filipino intersex individuals. As the first intersex Filipino legally allowed to change his sex marker in 2008, Jeff holds a significant role in the advancing of rights for the intersex community. Beyond his leadership in Intersex Philippines, he serves as the co-chair of Intersex Asia, contributing significantly to its growth and success. Thank you, Jeff.
Hello, and good day to everyone. Yeah. Next slide, please. Yeah. I will be talking as a leader in the intersex community, and also I was born with congenital adrenal hyperplasia, simple virilizing, and this is the issue faced by intersex person in the Philippines. But as I heard before, to our speakers before, it is also faced by other countries. So yeah, issues with birth certificate registration. Because when a baby is born, it's very hard, especially when it manifests ambiguous genitalia. Even the medical expert are finding it hard to distinguish whether what they are going to assign as male or female. Wait, there's a no. So yeah, having an intersex having a congenital adrenal hyperplasia especially those born with XX chromosome patterns, when they grow up and the age and when their puberty age, our body is different from the legal documents we have. I am assigned female at birth, but my body because of CAH, like manifest. I am now phenotypically male, so it's very hard. I've been bullied at school. It's very hard to get a job because of this, and because of the lack of awareness, not only by public but also of the service provider. Yeah. Increasing awareness and education among the healthcare providers, parents, and communities about CAH, its early signs and symptoms will make a big difference. So now at Intersex Philippines, we are also like having a dialogue with our medical expert and medical societies uh, about the sensitization and awareness campaign. So I remember in a research we did, majority of the people of the person born with ambiguous genitalia has a diagnosis of hermaphrodite. And you know, it's also a misconception. In the Philippines, yeah, it's very hard because I was also born with ambiguous genitalia, and the doctors put the diagnosis hermaphrodite. And because of the perception that like a hermaphrodite is born with two fully functional, uh, no, no, no. It's also we're on the right slide. Uh, so yeah, it's very hard because the diagnosis is hermaphrodite, and they think that it is two fully functional sex organ, which is one of the misconception of having an ambiguous genitalia. So yeah, that's why next slide maybe. Yeah, that's why I petitioned the court and the Supreme Court of the Philippines, which is the highest court in the Philippines, granted my petition to change my name and sex marker. That's way back in 2008. But until now, there's no law in the Philippines protecting our rights. Yeah, and that's why I decided to drop a bill, and this bill is now was filed in the Congress last November 2023, and it's now pending for hearing at the Committee on Justice. Yeah, but because until now, if you want to change name and sex marker, it is through judicial process, and it's very hard for us because it's costly and it's a tedious process. So next slide, please. So yeah, CAH is considered as one of top one in the list of rare disease according to Department of Health. But the thing is that, yeah, it's next slide. Yeah, we also have a rare disease app of the Philippines, which says that if you have this when you're in the list, it means that you have easy access to medicines. But this law was passed in 2016, but until now, there's no easy access to medicine, especially fludrocortisone and hydrocortisone in the Philippines. So yeah, that's also our problem. Yeah, next slide, please. And up to date, only one pharmaceutical company in the Philippines supplies medicines for those with CAH, including fludrocortisone and hydrocortisone. And this supplier is based in Metro Manila. Even specialized hospitals are based in Metro Manila. That's why it's very hard for like people like me living in rural areas and far provinces from the center of the capital in the Philippines to have access to medicine. It will cost us much, especially like when you want to do the chromosomal analysis also. It's very hard because there are only two like testing centers in the Philippines, and that two centers is located also in Metro Manila. So that transportation, like, it's very hard when when children are having adrenal crisis, yeah, it's very hard for them because the lack of awareness of like the medical expert living in rural areas and provinces, they don't treat adrenal crisis as an emergency because like the baby look normal and something like that, but they don't know that it's really life threatening. So we need to share awareness and sensitize even the medical expert about this. Next slide, please. Yeah. Before I show you like some of the pictures, yeah, I just want to like share what our organization is doing, Intersex Philippines. When we started, when the Supreme Court of the Philippines granted my petition to change my sex marker, people, intersex people born with CAH, especially those with ambiguous genitalia, and parents of children with CAH started to connect with me and told me how brave I am to go in front of the television and to share my journey as a person with CAH, because for them it's like they don't want to come to public because of the discrimination they will be facing. So yeah, and from then we started as uh, three members, and now we have more than 100 uh, people are member of our organization coming from the different parts of the Philippines. And just like 2 years ago, we included parents of persons with CAH in our organization because we knew that they are also facing challenges and issues with regards to like bringing up their children, supporting their children, because because there's no really resources in the Philippines that talks about CAH. It's very hard for them to find. Even when I'm searching back in 2005, the only resources I've seen is from the Western countries. And that's why now in Intersex Philippines we are like we're like making different resources like animation videos. I just launched our coffee table book, I Exist, where the lives of the intersex people and parents of children with CAH are experiencing, so that because we want to amplify our voices, because when nobody talks about it, the government will not act. So yeah. So we in Intersex Philippines we did our forums. We give livelihood programs to parents to ease the medication in buying medicines. Yeah, we do awareness campaigns in different cities, municipalities, and universities. We are also doing youth empowerment. Yeah, so and capacity training. So I think now I think next slide please. I just want to share, yes, this is a trigger warning because these are the pictures I am receiving every day. Next slide. And babies are dying because there's no accessible availability of medicines and non-availability of it. Just last night I received a report that a 3.5-week-old baby died because they live in the province far from Manila and there's no access to medicine. So next slide, because I don't want to trigger anybody. Yeah. So I just want to share that if we work together, we will, and with the help of our government and other support group around globally, we will reduce the mortality rate by 30% by 2030. I do believe in that. So thank you very much.
Thank you so much, Jeff. I'd now like to introduce Dr. Sumaro Sen-Ivache to speak on behalf of Sri Lanka. Dr. Sumadhu is a member of the Department of Pediatrics at the University of Colombo, actively involved in undergrad and postgrad education, clinical training, and research. He is an honorary pediatric endocrinologist at the Lady Ridgeway Hospital for Children and the director at the Center of Complex Hormonal Disorders at the University of Colombo. Thank you, Dr. Sumadhu.
Thank you for that kind introduction. Next slide, please. Thank you. So thank you very much for this opportunity to share some experiences from Sri Lanka. Sri Lanka is a beautiful tropical island in South Asia with a population of 22 million. And we have estimated prevalence of CAH of about 1 in 12,000, but possibly more, because in Sri Lanka too, we do not have newborn screening for CAH. So I belong to the Department of Pediatrics in the Faculty of Medicine, Colombo, and I'm privileged to be working in the first pediatric endocrine clinic to be established in Sri Lanka in 1999, so 25 years back, and was the only referral center for the whole country until the last 10 years. And so my presentation would be based on my experiences doing both clinical work and research in this cohort of patients we've been following up over this time period. Next slide, please. So I'll be talking to you about 4 research projects that we have conducted in Sri Lanka, and hopefully some of this data may be useful to my colleagues from other countries as well. I first got interested in research in CAH when I was doing my overseas training in Auckland, New Zealand, 2012 to 15, where I got the opportunity to study the outcomes of babies with CAH born in New Zealand, where they have had newborn screening for more than 30 years. And when I returned to Sri Lanka in 2015, I wanted to know what the situation was for Sri Lankan babies. So what we did was we looked at the data from all the children we were following. So some of them were quite adolescents at the time, but we looked at their original records and found that babies were being diagnosed at a mean age of around 20 days in Sri Lanka, which is not early enough, because we know that babies can die even around the 2nd week of life, but it was not too bad. But alarmingly, more than 80% of these babies already had evidence or features of impending adrenal crisis, which is the life-threatening situation at the time of diagnosis. And the age at diagnosis in girls was 10 days, and that in boys was 30 days. So boys were being diagnosed later, probably because they do not have the genital abnormalities to alert the medical professionals. And we found a male to female ratio of 0.4 to 1, suggesting that maybe up to 60% of boys were losing their lives in Sri Lanka, leading to this gender inequality. We also found some interesting other facts during this study. We found that half of our patients came from ethnic minority groups, whereas the national rate is only 24%. And we felt that this was probably due to higher rates of marrying second cousins between the ethnic minority groups compared to the majority group. And this was confirmed by a high rate of first-second cousin marriages between in the parents. 27% of the families were between second cousin marriages, whereas the national rate is around 7%. And 10% of the babies born with CAH already had older sibling with CAH when they were conceived. So we don't know whether the parents received the necessary education. And sadly, 7% of families already had lost one child earlier with unrecognized, most likely unrecognized CAH. They were unexplained deaths in healthy babies. So all this, I think, really enforces the importance of newborn screening in countries such as ours. And for anyone who wants to use this research for their own advocacy purposes, we are most happy to share this. We also found, next slide please, though it seems that the boys were losing their lives, we also found quite significant issues in girls with CAH due to the in vitro virilization they face because of exposure to excess male hormones while in the mother's womb. So almost all the girls who were born had virilized genitalia or atypical genitalia, and half of them had very severe virilization, Prada stage 4 to 5, which shown in the image in the last two figures. So some of them would have even been mistaken as boys. And this was more than half of the families we included said that they faced gender uncertainty at birth, as just mentioned. So the parents were told they couldn't be told whether it was a boy or a girl, leading to long-lasting psychosocial consequences in many of these families. And sadly, 10% of these girls were misidentified as boys. So they were given a birth certificate which said a male name and a male gender. And sadly, even though there was evidence of genital virilization, which could hopefully have alerted and prevented adrenal crisis, more than half the girls also had started developing low sodium levels at the time of diagnosis. So this suggests that even in girls, newborn screening would probably help to reduce mortality and morbidity from CAH. Next slide, please. Next slide, please. Thank you. So, I'm so sorry, previous slide, my mistake. So all this work was nicely leading up to support for newborn screening in CAH, but unfortunately in 2021, Sri Lanka underwent one of a major economic crisis, worst in last 70 years, leading to it not being feasible at the present time. But we have been educating all the families with a child with CAH with a leaflet so that the parents are aware. We speak to them about this, and we've made representations to the Family Health Bureau, which is the preventive, the government agency working with on the preventive health side, about the need to educate health staff at delivery units and the public health midwives who visit all the babies born in Sri Lanka in the community in the first 10 days of life, to be more vigilant about babies with atypical genitalia and the other features of CAH, to help us to identify these babies earlier. And I think there's a big need to educate high-risk communities, and hopefully these efforts will help us to reduce mortality and morbidity until newborn screening can be established. Next slide, please. We were concerned about the virilization in girls and the outcomes. So we're very lucky to have a very dedicated pediatric surgeon in our hospital who does most of our surgeries. And we did an outcome survey of the girls with CAH who had undergone surgery. There's very little research data out there, especially from low middle income countries. And in our cohort of 27 girls, we found that many of them had surgery early, mean age of 3.5 years of age. And they had quite significant male-like genitalia at the time of surgery, Prada stage 4 in almost half of them. The surgery was vaginoplasty and clitoral reduction and labioplasty to make the genitalia appear more like female. But in many cases, 83%, it was just one major surgery that they needed. And we found a very high level of parental satisfaction. More than 70% of the families agreed that the surgery helped to reduce their psychosocial issues that they were facing, anxiety. And even the girls themselves, which we've been seeing them for many years now, none of them have shown any discomfort about having surgery. I think it was happened at a young age, and I think that probably would have saved them from some psychosocial distress. Next slide, please. Thank you. So we know that girls with CAH have male-like genitalia because they're exposed to high levels of male hormones in the womb, and this can also affect their brain, the way their brain functions. So again, there's very little data out there, no clinical screening tools are available. So we found this gender identity questionnaire for children, and we translated it into the local languages and looked at 27 girls with CAH and compared with healthy girls and boys without CAH. And we found that girls with CAH had lower scores than the healthy children, scores of less than 4, which indicated they were having some atypical behaviors, not typical male, like it should have been 1 to 2, but something in between. And so this means that it's important for us as healthcare providers to be aware, and I think support groups to be aware that some of these girls may be facing some psychological issues, and this really, I think, illustrates the importance of having multidisciplinary care with pediatric, surgical, and psychiatry teams working together, and we've been successfully doing that for the more complicated patients in our cohort, and the need for psychosocial support and support groups, hopefully to help these girls to cope better with their as they grow up. Next slide, please. And we were interested in looking at the data on quality of life of children and adolescents with CAH. Unfortunately, we couldn't find any systematic review which had, collectively looked at the global data. So we recently, last month, this article, we wrote this article looking at global data, which was published in the JCA. We're happy to share that with anyone who is interested. And what we found was that when you looked at both developing and developed countries around the world, the research which has been done up to now, it shows that children and adolescents with CAH have impairment in their psychosocial quality of life rather than their physical quality of life. Although they have a medical condition needing lifelong medication, the main effect was on their psychosocial health. And I think this really underlies the importance of social support groups for such children. Based on this research, we then started looking at quality of life in our children followed up in our unit using the PED-QL questionnaire, and we found that while the boys were not having lower quality of life, girls with CAH had lower quality of life compared to age-matched healthy girls without CAH in Sri Lanka. And the factors within those with CAH which were associated with poorer quality of life was poor compliance with medication and belonging to an ethnic minority group. The poor compliance with medication may not necessarily indicate unwillingness to take it, but rather problems with access and easy access to medication as well. So next slide, please. So all these I think really emphasize the vital importance of long-term medication, access to long-term medication. We were very fortunate in Sri Lanka to have government funding for medication for many years, for as long as I remember. But in 2022, in the economic crisis, we as healthcare providers, we are facing major problems with lack of availability of hydrocortisone and fluorocortisone. So we are very grateful to CAH, who came in at this time, very timely need, and we are very lucky that all our children have continued to have uninterrupted access to this medication, thanks to CLAN. We also created a Medi-Alert card, because during COVID we were wondering what was happening to our children, and after that we've now started issuing this Medi-Alert card to all our patients so that they can carry it in their class, in their school bags or other with them as they go about in their daily lives. Next slide, please. So Jeff, it was very interesting hearing your story, and our children share similar experiences in Sri Lanka. Up to 10 children with not only CAH but DSD also we have in our cohort who had erroneous birth certificates, and it was causing very significant psychosocial issues to them. Many of them had tried legal processes without success. So I was very fortunate to have support from two wonderful ladies in the Asia Foundation, who we've been working over the last 3 years, and we've now managed to have a nice procedure where without legal support they can go directly to the Registrar General's department with a letter, and Asia Foundation has been helping them at every step. It's been amazing, amazing work, and we are very happy that the 7th child with CAH got her clear birth certificate last week. She's a 23-year-old university student, so I think it will be a huge boon for her career as well, not to have this. And I was so happy when we reached out to her and asked her whether she would like to lead the parent support group. She was very happy, and I'll be speaking about that later. And we are working to establish a government circular where even without mediation of Asia Foundation, anyone born in the future with intersex disorders could be able to have this.
Sorry, Dr. Suvadu, we might have to wrap up there. Is there any last remarks you would like to make?
Yes, please, the next slide. So we are very happy that we are going to start establishing a CAH support group in Sri Lanka, and it's been amazing listening to the experiences by Trudy and Jeff, and we hope we will have your support. It's a new venture for us, and we are really hoping to have some good outcomes following the establishment of this. Thank you.
Thank you so much, Dr. Suvadu. I'd now like to introduce you to Dr. Agustini Utari to speak on behalf of Indonesia. Dr. Agustini is a consultant pediatric endocrinologist at the Pediatric Endocrinology Division in the Ponggoro University, Semarang, Central Java. She is currently Vice President of GPED, a member of the International Pediatric Association Strategic Strategic Advisory Group on NCDs and Mental Health, and is a board member of the Pediatric Oncology Working Group, Indonesia Pediatric Society. Thank you, Dr. Agostini.
Thank you and greeting everyone. Thank you for Clan who invited me to talk in this meeting. And I'm very grateful to be here, and I'm glad to have an opportunity to share about the experience of optimizing diagnosis, treatment, and support for CAH communities in Indonesia. Slide. We know that the delayed diagnosis of CAH may lead to important clinical consequences with impact of comorbidity and patient survival. And if untreated, CAH may be fatal or may be responsible for long-term consequences and psychological problem. So there are numerous challenges that we must resolve in developing countries with limited resources, such as Indonesia, where newborn screening for CAH is not available yet, and some limitation about the availability of medication. So we will focus in this meeting that we will discuss about the newborn screening program and also the medication. Slide. Yeah. So I will start a little bit about the demography of Indonesia. So Indonesia is the largest archipelago in the world from a single state and consists of more than 17,000 islands. And we have 34 provinces with 514 districts or cities in Indonesia. And here we have a population of 278 million people, and we have 4.8 million baby born in a year. So it's a very big population. However, we only have 39 pediatric endocrinologists and 40 fellows available in only 17% province of Indonesia. Slide. And from our data registry of CAH, from 4.8 million baby born, we only found less than 500 patients with CAH in Indonesian Pediatric Society registry within 11 years of registry. So if we see the global incidence, we must have more than 300 babies born every year with CAH. We assume that patients are undetected or self-wasting that already passed away because of self-wasting condition, which also similar features with gastroenteritis or infectious diseases. Slide. And nowadays, newborn screening for CAH is not available in Indonesia. And from the data of Indonesian registry, we found that the male to female ratio of CAH were 1 to 4.3 in 2009 and improved in 2020 with male to female ratio around 1 to 2.2. We assume that the lack of CAH newborn screening result in the lack of early diagnosis and lead to the increased mortality rate, particularly in the male patient who do not show ambiguous genitalia. And our cohort database of 78 CAH patients. Next slide, please. So before 2000, so this data is in 2016 when hydrocortisone is still not available legally in Indonesia. And we reported 12.8% patients were reported died due to adrenal crisis. And we also noticed that only 5% of 46XY patients, CAH patient, so it may indicate that adrenal crisis in male newborn might be underdiagnosed or unidentified. And we also find 9 siblings of 7 family had a history of sibling who already passed away because of self-losing crisis before diagnostic confirmation. So we can see here that there's a late, also the late identification and maybe a lot of male already passed away. Slide. And this is the problem in Indonesia. So I will focus on the diagnosis and access to medicine. In the diagnosis, you have no newborn screening available this moment. Lack of knowledge about CAH, late identification of disease, late referral, late diagnosis. And the problem is also about the laboratory availability. 17 OHP was not covered by health insurance in our country, and only in the a private laboratory and one province lab in Jakarta that can do 17 OHP analysis. And about the access to medicine, CH is a long life treatment, and we fortunate that we have already hydrocortisone available in Indonesia since 2018, and it's now covered by government health insurance. However, fludrocortisone was not available until August 2023. So we got the medication from other country, and of course with the very difficulties, transportation and other. Slide. Yeah, slide. And with a long journey, finally, we are happy that fludrocortisone now with a brand name of Sitnacort available in Indonesia. However, we see that there is a long way to get the fludrocortisone available in our country. Yeah, the development was started in 2018 and completed in 2020. However, the registration started in May 2021 and the approval issue in June 2023. And we already launched this product in August last year. However, this medication is still not covered by health insurance because fludrocortisone is not available in the national formularium for medication in Indonesia. So in Indonesia, when the medication is not in the list of national formularium for medication, so it will not cover by government health insurance. So we still work on this. Slide. So this is a Sitnacort that already available in Indonesia. Slide. And the other thing is about the newborn screening, because after Sitnacort launched last year, so the medication is already available in our country. So the government think about the expand of the newborn screening program. And here we see, sorry, this is in Indonesian language, the table, but we can see here that since 2023, we can see the increasing number of newborn screening for congenital hypothyroidism. So this is actually the newborn screening for congenital hypothyroidism, because in Indonesia, we only have one newborn screening that nowadays covered by the government. So since September last year, our government made a decision that every labor must include newborn screening for fee claim in the national health insurance. So we can see in this table that since September, our newborn screening rate was significantly increased. Before this time, we only reached around 3% coverage. And until December 2023, we reached almost, here is 28% of the baby. So this is a very significant increase of newborn screening coverage in Indonesia. And the Ministry of Health is trying to increase to more than 80% coverage after this in this year. So after successful in the increasing number of congenital hypothyroid screening, the Indonesian Ministry of Health has a plan to extend to the other screening, included congenital adrenal hyperplasia and G6PD. So this is the pilot project of newborn screening in Indonesia. We started to discuss about this extent of newborn screening in October last year. And in December last year, we already developed guideline for CH pilot project in Indonesia. And we plan to do we already prepare for the laboratory preparation and plan to start in April this year. And this is the referral laboratory for CH newborn screening for pilot project. So this is only pilot project, but we will cover 77 districts in 4 laboratory, the big laboratory in Java. We still try to do in Java Island because with the easier transportation and other. Slide. And this is our meeting to discuss about the extent of congenital adrenal hyperplasia screening. And also in December, we developed the CAH guideline for a pilot project. Slide. And our future plan is to propose to put fludrocortisone to national formularium as an essential medication. Then it can be covered by government health insurance, and of course, the establishing CAH newborn screening for larger coverage. And to close, I would like to acknowledge the contribution of Ministry of Health, particularly the Expert Commission of Newborn Screening Program, the Indonesian Pediatric Society and CLAN, and special for Kate and also Aman Pulungan, who always support for CAH program. Thank you so much.
Thank you so much, Dr. Agostini. I would now like to introduce Dr. Paola Duran to speak on behalf of Colombia. Dr. Paola is the Chief of Pediatric Endocrinology Service at the Foundation Cardio Infantil Bogota, Colombia. She is the Director of C-Endo Foundation. She's a Professor of Pediatric Endocrinology at Universidad de Lázaro, Universidad del Bosque, and Universidad de La Sabana, Bogota, Colombia. Thank you, Dr. Paola.
Hello. Thank you for the invitation to share our experience with amazing people around the world. I would like to talk to you about our first Colombian CAH club meeting that took place only 3 days ago here in Bogota. Next, please. So Colombia, these are colors and amazing people. We have a population of 52 million. Next, please. We are rated as an upper middle income economy country. The infant mortality rate is 11.04 deaths per 1,000 live births, and the under 5 mortality rate is 13 per 1,000 births. Colombia, Latin America is the world's second most unequal region, and Colombia is the most unequal country in the region. Next, please. So we began our collaboration with CLAN in March 2023, a year ago. CLAN has been our inspiration, our mentor, and our guide along the way. We have been having bi-weekly Zoom meetings, and CLAN has generously shared its expertise, knowledge, including extremely valuable tools. Next. So we developed the health need assessment survey based on most of the templates of Dr. Kate Armstrong thesis. We also use the Czech score. We use the Vietnam publication of Dr. Kate Armstrong. And also we use a survey we had made in Colombia. So we adapted the survey to Colombia and applied it to 6 patients living in Bogota before we used it in our club meeting. Next. So we had an H&A survey with 112 questions in Spanish. It's a survey mainly for caregivers, and it focuses obviously on CAH. We had the survey transcribed on the RedCap platform, and we also obtained the ethics committee approval for this event. Next, please. So the Foundation C-Endo in Colombia, the Colombian Endocrine Pediatric Society, the Pediatric Society CLAN at La Fundación Cardio Infantil, which is a referral hospital in Bogota, the capital of Colombia. We had the first CAH club meeting on March 10th. Next, please. So going through the pillars of a CLAN strategic plan, in the first Colombian CAH club meeting, we have 111 assistants between patients and family members. There were 32 families, and all the families completed their health need assessment. So this is the first pillar to encourage family support group. Next. We had 9 boys and 23 females. Next. And we separate them in groups 11-year-old and less, in which we have 10 patient or 10 children, and we had 4 boys and 6 girls. Next. And 11-year-old and older, we had 22 children and young patients, 5 boys and 17 girls. Next, please. The last year at the UN Summit in September, we had talked to you about Juan Pablo Lopez, who is now a 10-year-old young male. He's a medical student. He lives in Cali, which is another city away from Bogota. He lives with CAH, and he was willing to be a community leader. He presented a poster at the meeting, at the pediatric endocrinology meeting, about him. And so I am pleased to tell you that Juan Pablo came to our first Colombian CAH club meeting, and he presented his testimonial, and he inspired with his story all the young children and gave them hope. We also had the privilege to have Dr. Kate Armstrong and Dr. Maria Craig with us at the first club meeting. Next, please. The second pillar, education, research, and advocacy, was also, we also did some in the first Colombian CAH club meeting. We did some material in Spanish, and we gave the patients the children some links where they could read. This was a plastified flyer, so they could keep it. And we gave them the instructions and how to behave when they have sick days. And they really liked that. Thank you. Next, please. We also talked about optical medical management. We have also a social worker who helped us explain to all the families how to navigate the Colombian health system and where to find solutions in case that they could not access the medical clinics. Next, please. And the fourth pillar was access to medication and equipment. In Colombia, since December 29th of 2023, all the glucocorticoids, hydrocortisone included, are in the list of essential medicines, and also fludrocortisone. In Colombia, they are available, but they are not guaranteed because there are some barriers in the health system, as we will see. Please, next. So today since it was 3 days ago, I will only tell you the impact and the reactions from children and their families, but I cannot give you all the data. I will present it to you in our next meetings. But what we most understood in that meeting is families need to be heard. They had gratitude with the first opportunity to meet and get to know each other. Most of the children and young persons that attended have never met another person with a congenital adrenal hyperplasia. We also had the creation of a support network, and 4 families volunteered to lead, and they have been working on it all week, very enthusiastic. In the young people community, they found the Instagram, and they now have a community in Instagram to get connected one to each other. Please, next. The main worries we could identify with the questions and what the families were talking about was, first, lack of education. They were all very worried. Some of them didn't know about the emergency injection, and it was very important to them to learn about that. We also had a long talk about genetics because they wanted to understand better who was a carrier and who was affected with the condition. Also, access to medication, even though it's in the essential medicine list, there is restricted access due to system operational issues, and it is not guaranteed, and we have to keep advocating and working so it is available to all children in Colombia. Next, please. So now I would like to introduce Angela Castro, who was one of the young girls with us at the first CAH club meeting in Colombia. And she would like to share with us today her experience of living with a CAH in Colombia. Angela will be speaking Spanish and I'll be translating for her so we can understand from her voice how it is in Colombia. Angela, bienvenida. Por favor, abre el micrófono y puedes empezar a hablar.
Buenas noches a todos. Mi nombre es Angela Nicole Castro, tengo 17 años y soy una paciente colombiana con hiperplasia suprarrenal congénita. Y me gustaría compartir un poco con ustedes los desafíos que he enfrentado en mi país por mi condición.
Good night to everyone. My name is Angela Castro. I am a 17 years old female and I live with congenital adrenal hyperplasia. I would like to share with you my history tonight.
Me gustaría contarles sobre una experiencia que tuve en mi colegio. A los 8 años tuve una crisis adrenal y nadie supo cómo controlar.
I would like to share with you a story when I was 8 years old at school. I had an adrenal crisis and nobody knew how to deal with that.
Durante esta crisis me desmayé y le informé a la profesora que estaba a cargo que me sentía mal, pero no recibí ayuda de su parte. No entendía qué estaba pasando ni por qué me sentía tan mal. Tuve que afrontar esta situación sola. Me enviaron a la recepción del colegio donde estuve casi inconsciente hasta que llegó mi mamá.
I almost fainted. I was feeling very bad. I tried to talk to my teacher, but she wouldn't help me. She sent me to the reception of the school to wait for my mother or someone to help me. I had to face that by myself.
Parece ser que no registraron correctamente la información que les había dado mi mamá desde el principio. Finalmente mi mamá llegó y tuvo que darme mi medicamento vía oral, ya que en mi país no nos autorizan la inyección de emergencia que es necesaria en casos como este.
Even though my mom had been to school and talked to them about my condition, apparently they didn't take it seriously. Nobody knew what to do. When my mom arrived, he gave me the oral medication because in Colombia, we do not have the emergency injection to carry with us at all times.
Ella me llevó al hospital más cercano donde no conocían sobre mi condición y por ende no pudieron atenderla. Tuvimos que salir de ahí y ir a un hospital que está mucho más lejos, pero donde nos sentíamos más seguras para atender las crisis adrenales. Este está a 17 kilómetros de distancia, lo que fue 1 hora de recorrido.
She took me to the nearest hospital, but they didn't know how to handle my condition or didn't understand. So my mom decided to take me to a hospital where we feel safe, which is at 17 kilometers away from my house, and it took us an hour to get there.
Hoy a los 17 años, al mirar hacia atrás y ver un poco más consciente la situación, sé que soy de los pocos casos que existen que tienen la fortuna de tener una mamá como la mía, una mamá que es enfermera y se educó sobre mi condición desde el principio y me ayuda a tener una calidad de vida digna a pesar de mi enfermedad.
Today, at 17 years old, when I look back, I understand better everything that happened and that I am very privileged to have a mother who is a nurse and who got education about my condition and had helped me have a good life with congenital adrenal hyperplasia.
Sé que en otras condiciones, quizás con un poco más de desinformación y en otros sitios de mi país sería mucho más difícil tratar esta condición.
I understand that it's not the same for everybody in Colombia. And if I had been at another place, and if I had not had the help of my mother, it could have been different and my story could have been worse.
De hecho, hace poco estuve en la primera reunión del Club Colombiano de Pacientes que viven con HSC y me di cuenta que tenemos un camino inmenso por delante, lleno de desafíos para combatir todo el desconocimiento y actuar con más capacitación frente a los desafíos que nos enfrentamos las personas con mi condición.
I attended the first CAH club meeting in Colombia, and I met some other people and some other children with CAH. And now I understand all the work we have to do, all the education and everything we have to do to help everybody have the same, have equity, to have the same opportunities in Colombia.
Hoy quiero alzar la voz por todos los niños y niñas que viven con HSC en mi país, para que todos tengamos las mismas oportunidades y podamos tener una vida linda, con resultados felices como la mía, una vida donde tengamos sueños y metas por cumplir y podamos dar amor y recibirlo a pesar de nuestra enfermedad.
Today, I want to raise my voice for all the children that live with CAH in Colombia, so we can all have the same opportunities, and so we can all have access to education, to live a good life with dreams, with goals, and to receive and give all the love we want to give.
Agradezco su atención y apoyo en este tema tan importante. Muchas gracias y feliz noche.
I thank you for letting me share my story and for listening to me tonight and to have this opportunity. Thank you very much. So
Thank you so much, Angela, and thank you, Dr. Paola. I would like to now transition back to Kate for our closing remarks and recommendations.
Oh, wow, what a powerful presentation to finish off with. Thank you so much, Angela, for sharing your story and your story of what happened in school. I've just included a link there to a video for schools that might help teachers learn more about CAH as well. But it was a privilege to meet you at the meeting in Colombia, and thank you, Paola, for that presentation. I'm mindful that we've come to the end of our time, and I just wanted to thank everybody most sincerely for sharing stories and updates on the incredible work you're doing around the world to improve health outcomes for everybody living with CAH. It was wonderful today to focus on efforts we can make to accelerate gender equality, but I have so much to take away and process, and I'm sure we all do. And I do think this has been a wonderful chance for us to listen to stories from high-income countries, low-income countries, everywhere around the world, and just see how different things are in different countries and all the work that we need to do. There's a lot more that we need to do on the road to 2030, but I'm confident if we all continue to work together that we will make a difference. So thank you very much. Our team will be putting together a report on today's event, and we'll be sharing a recording of the video. I want to say a special thanks to Mabel, Elizabeth, all our young team for putting together such an excellent event, and I hope that we will all be together again soon. So thank you very much, Mabel.
To everyone, our event has now concluded. Thank you for everyone who's been involved for your support in the success of this event. If you'd like to get in contact with CLAN or keep up to date with what we're doing, please follow any of the links on the slide shown. CLAN is unwaveringly grateful for the support of the CAH community and Mates for Kids Network for allowing us to do the work we do. And we hope that your support will continue into the future, so we continue to have an impact on our work. A recording of today's event will be available, and a report will be available on the Mates for Kids website and the WHO Knowledge Action Portal. If you would like to keep up to date with the activities of Mates for Kids, please subscribe to the WHO CAP and visit the CLAN and Mates for Kids websites, or follow us on any social media platforms. Our contact information is available in the slides now. Please don't hesitate to get in touch and learn more about the work that CLAN and Mates for Kids do. We look forward to what we can achieve when we work together to make newborn screening accessible and leave no child behind. Thank you once again.